Arterial leg ulcers, or ALUs, can develop due to inadequate blood supply of the skin. They compose up to 20% of non-healing lower extremity ulcers, and if they go untreated, they present a significant risk of amputation. ALUs are also a sign of a deeper issue, peripheral arterial disease, which has an overall survival rate that is worse than many cancers, with a 5-year all-cause mortality of 50%. In this Smith+Nephew video, we're going to take a look at ALUs. We'll see how to identify an ALU and how they form, what you can do to assess and treat an ALU, and how you can prevent one from happening. Let's get started. First, what is an arterial leg ulcer? As the name suggests, this is a chronic ulcer on the leg, usually below the knee or on the foot. They are caused by poor blood flow to the limb that hinders the body's ability to heal properly. You can generally identify an ALU by its round shape and deep punched-out appearance. But arterial leg ulcers are found in conjunction with a bigger problem, peripheral arterial disease, or PAD. This is a condition in which arteries that carry blood away from the heart down to the feet become either clogged with plaque or lose their elasticity due to hardening. An estimated 20 to 50% of all people with PAD are asymptomatic, so your patient may not even know they have it. If you see a leg ulcer, check for signs of PAD. For a quick assessment, you can use the 6 Ps: pallor, pain, paresthesia, paralysis, pulselessness, and pyochilothermia. Pallor. You may first notice that the skin has a pale, white, or ashen appearance. This is due to low blood flow. Next is pain. Your patient may experience sudden and intense pain in the muscles. Early on, this pain may come and go after walking or exercise, but as the condition worsens, your patient will feel it even when resting. Paresthesia. A tingling sensation or numbness of the limb. This numbness can even occur along with the ischemic pain. Paralysis. As the condition progresses, your patient may experience muscle weakness or complete paralysis of the limb. Pulselessness. If the blood flow has been significantly compromised, you may not even be able to detect a pulse in the affected limb. And lastly, pyochilothermia. The limb may be cold to the touch. If you actually see all 6 of these symptoms, there is a good chance that this person is experiencing acute PAD, which is very serious, and you should refer them to further testing immediately. Although later in this video, we'll give you a more thorough and precise assessment tool. Now let's take a look at how an ALU forms. Before the wound even forms, PAD can be present. It'll start as plaque builds up in the arteries, reducing blood flow. Next, your patient will begin to notice pain and cramping. First, after walking or climbing stairs, but later even when resting and sleeping, although patients with neuropathy may not feel this. As critical limb ischemia sets in, the skin on the feet or toes may turn pale or blue and feel cold. This is the point where an ALU may start to form. An ALU normally forms in one of 2 ways. The most common is in the form of a pressure ulcer. This comes from prolonged and sustained pressure or shear on the tissues. This can be from too much standing or walking, or even from resting the limb in the same position for too long. This pressure squeezes the fluids out of the cells, and due to the reduced blood flow, those fluids can't replenish and the cells die. The second way they form is from a common everyday acute wound like cuts, scratches, and bruises. When a patient has critical limb ischemia, these acute wounds can quickly become chronic. In the final stage, if blood flow is restricted for too long, tissue will begin to die on its own and gangrene can set in. If this is not treated immediately, your patient may need amputation. ALUs and PAD are serious matters, and amputations are common. That these wounds are not just going to heal on their own is important, and in many cases, revascularization is necessary to aid the healing process. Your goal should be to catch PAD as early as possible and refer them to a vascular specialist. After seeing how an ALU forms, you might be thinking of different types of people who are likely to get one. Here are some who are at high risk. First, people with PAD. Second, people over 65. Smokers, as this reduces the amount of oxygen in the blood and constricts blood vessels. People with diabetes. These people can get a specific type of PAD that involves microvascular disease, which can add another layer of difficulty to manage. People with hypertension, as high blood pressure can damage arteries, leaving them susceptible to plaque buildup. And people with hyperlipidemia, as high levels of cholesterol and triglycerides contribute to plaque formation. Lifestyle factors can also increase risk, including a sedentary lifestyle, unhealthy diet, and lack of exercise. Before we get into assessing and treating an ALU, you should know that most ulcers will be mixed. That means you have to deal with more than one type of wound at the same time. Like we said before, an ALU can start from a pressure ulcer or an acute wound. Also, since people with diabetes are likely to have PAD, your ALU may also be a diabetic foot ulcer. And people with PAD are also likely to have venous insufficiency, so your ALU may also be a venous leg ulcer. All this to say that these ulcers are complicated, and doing your homework on different types can really make a difference in helping your patients avoid amputation. Now let's look at how we can assess and treat an arterial leg ulcer. You might be familiar with the basic steps in wound treatment: cleanse, debride, control infection, and dress. But an ALU can be a catastrophic wound, and you'll need to take additional steps in treating it. First, as we said before, these wounds will not heal without improving blood flow to the area, so revascularization is crucial. Also, administering antiplatelet agents or statins can help manage PAD. Finally, managing underlying risk factors like diabetes, hypertension, hyperlipidemia, as well as smoking cessation are all keys to helping ALUs heal. When assessing an ALU, you have a lot of assessment tools to choose from, but the IWGDF recommends the WIfI classification system. WIfI is specially designed for lower leg wounds where there is a threat of amputation. The acronym stands for wound, ischemia, and foot infection. For each category, you'll give a rating from 0 to 3, and each rating will show you how to modify your treatment plan. In this video, we'll first jump ahead to the ischemia rating, as we find that this rating helps us form a baseline for specifically treating an ALU. An easy way to think of WIfI is like this. Ischemia gives you an understanding of their vascular condition, how likely it is that they have PAD, and what measures you should take first. The wound category gives you an understanding of how far this wound has progressed and how to manage it. Finally, foot infection lets you ascertain the external bacterial threat that the patient is facing, although patients with PAD may not show signs of infection. Let's start with ischemia. The higher the number, the more difficulty it will be to heal this wound, and the higher the risk of amputation. To grade ischemia, you'll need to take 3 measurements. First, the ankle brachial index, or ABI. Second, the systolic blood pressure of the ankle. And 3, the systolic blood pressure of the toe. The ABI gives a better indication of how likely the person is to lose a limb, while toe pressure is a better indicator of how likely the wound is to heal. In addition, toe pressure can be more reliable because if the arteries have hardened, your ABI reading can be abnormally high. If in doubt, look to your toe pressure reading. Also, you should use at least 2 of your measurements when you are grading ischemia. The methods for taking these measurements are a bit outside the scope of this video, but refer to the IWGDF guidelines if you need help. The first grade is 0. Grade the ischemia as a 0 if 2 of the more following are present. The ankle brachial index is greater than or equal to 0.8. the systolic blood pressure of the ankle is more than 100 millimeters of mercury, and if toe pressure is greater than or equal to 60 millimeters of mercury. This patient has adequate blood flow, and this wound is likely not an ALU. You should reassess at this point, and you may want to look at venous insufficiency or neuropathy as major contributors. 1. Grade the ischemia as a 1 if the ABI is between 0.6 and 0.79. The ankle SBP is between 70 and 100 millimeters of mercury, and toe pressure is between 40 and 59 millimeters of mercury. This indicates mild ischemia, meaning you should be aware that ischemia, in part, may have caused this wound, so be on the lookout for other contributing factors as well. This level of ischemia can cause delayed healing. There are a few things you can do to help things along. First, consider using topical agents that promote blood flow and tissue granulation. Second, you can also consider using antiplatelet agents or statins at this point and encourage your patient to stop smoking, get regular exercise, and eat healthy meals. 2. Grade the ischemia as a 2 if ABI is between 0.4 and 0.59. The ankle SBP is between 50 and 70 millimeters of mercury, and the toe pressure is between 30 and 39 millimeters of mercury. Now we're moving into moderate ischemia, and you can be more confident that the wound is an ALU and that you're dealing with PAD. At this point, you'll want to conduct more complex tests and bring in a vascular specialist. It's highly likely that this patient needs revascularization. There's another option that many people wouldn't think of using, and that's a negative pressure wound therapy system. A lot of us imagine that this is just a system used for removing exudate, but negative pressure dilates blood vessels and improves local blood flow and lymphatic function. Plus, it can protect the wound from external infections as well. 3. Grade the ischemia as a 3 if the ABI is less than or equal to 0.39. The ankle SBP is less than 50 millimeters of mercury, and the toe pressure is less than 30 millimeters of mercury. This is severe ischemia, and it's urgent that the patient be hospitalized. You should refer them to a vascular surgeon and a multidisciplinary team right away. Wound. Now that you understand the level of ischemia you're dealing with, let's rate the wound itself. Keep in mind that it's unlikely that the wound will heal without revascularization. So your main goal here is to manage the wound until the procedure can be done. We'll also rate this from a 0 to 3. 0. If you don't see any exposed wound or signs of deep tissue damage like bruises, then grade this wound at a 0. You essentially have no wound here. At this stage, maintain the preventative measures of controlling blood sugar, treating hypertension and hyperlipidemia, and encourage smoking cessation. Although, if they're experiencing ischemic pain, you'll want to monitor those areas closely and test for PAD. 1. When you start to see a small, superficial ulcer, but with no gangrene present, then grade this wound as a 1. At this stage, use the 4 basic steps of cleansing, debriding if necessary, infection control, and using an appropriate dressing that helps to maintain a moist wound environment, as ALUs are more likely to be dry wounds and heavy exudate is not common. Even though this wound may seem insignificant, a retrospective study showing that patients with diabetes who did not receive revascularization within 2 weeks of an ulcer forming had a significant increased risk of loss of limb. So even if their wound is graded as a 1, if their ischemia rating is a 2 or a 3, then you should treat this as a serious wound. While revascularization is key, if the wound is on the foot, offloading it is important. You can use a total contact cast or removable cast walker if applicable. 2. If it progresses to a deep wound with exposed bone, joints, or tendons, then you should grade this as a 2. If you see gangrene, it should be minimal and only be found on the toes. Amputation is more likely at this stage, and you'll want to implement more aggressive treatment measures. You may need more frequent cleansing and debriding, and stronger infection control measures. At this point, osteomyelitis and bone infection is a real concern, and you may want to schedule imaging for your patient. If your patient has already undergone revascularization, other options you can consider are growth factors and skin substitutes, as they can help rebuild the wound bed. It's important to note, however, that these treatments are not available in all locations. 3. If the size of the ulcer is extensive, large enough to cover the forefoot, midfoot, or calcaneus, grade it as a 3. Extensive gangrene would also warrant this classification. You should be doing everything you did for grade 2, but now you should strongly consider hospitalization. There is a high chance that the leg or foot will need to be amputated. A patient with a grade 3 wound is also likely to be in pain, even if on an insensate foot or limb, so you may want to consider pain management strategies. Infection. Lastly, we need to rate the level of infection. Like ischemia, this grade will tell us how difficult it will be for the wound to heal. 0. If there is no infection, grade it as a 0 and continue your treatment as normal. 1. If you find a mild infection that only includes the skin and subcutaneous tissue, rate this as a 1. This will show up as non-blanchable erythema, but it should only cover an area between half a centimeter and 2 centimeters around the ulcer. At this stage, you'll want to regularly debride the wound and use topical antimicrobials or antimicrobial dressings. Consider systemic antibiotics if there is a sign that the infection is spreading, but make sure that you use good antibiotic stewardship. 2. Rate a moderate infection as a 2. This includes infections that go deeper than the skin and have non-blanchable erythema of more than 2 centimeters. At this stage, you'll want to consider hospitalization and consult with an infectious disease specialist. You'll also want to start treating the patient with systemic antibiotics. Employ a negative pressure wound therapy system to help control the wound, and schedule imaging to look for osteomyelitis and deep abscesses. 3. Rate the infection as a 3 if you find severe infection with systemic inflammatory response syndrome. The patient should have 2 of the following symptoms: fever, tachycardia, tachypnea, or an abnormal white blood cell count. At grade 3, the patient needs to be hospitalized immediately and given intravenous antibiotics. You'll also want to consider surgical interventions for debridement and draining of any abscesses. This is the extent of using the WIfI system to help form your treatment plan. Remember, think of it like this. Ischemia gives you an understanding of their vascular condition and how likely it is that they have PAD. If they do, bring in a vascular specialist, and you can consider modifying your treatment plan with antiplatelet agents, statins, and negative pressure wound therapy. Wound gives you an understanding of how far the wound has progressed and how to manage it. And infection helps you ascertain the foreign threats that the patient is facing. Topical antimicrobials, antimicrobial dressings, and systemic antibiotics are common interventions here. Prevention. Now that we've looked at how to assess and treat an ALU, let's see how to prevent one in patients who have peripheral arterial disease. First, as we said before, catching PAD early and referring them to a vascular specialist is the best way to deal with the issue. And administering antiplatelet agents and statins help in improving blood flow. But there are a few things that patients can do to prevent an ALU. The first is that they check their legs and feet daily for minor injuries and bruises. They can also help prevent pressure points by wearing proper footwear, well-fitting socks, and offloading their feet when they're sitting for long periods. They also need to manage underlying risk factors like diabetes, hypertension, and hyperlipidemia. Finally, they should consider lifestyle changes like quitting smoking, getting light exercise, and eating a healthy diet. This wraps up our Smith+Nephew presentation on ALUs. Today, we looked at how to identify an ALU and how they form, what you can do to assess and treat an ALU, and how you can prevent one from happening. I hope this will guide you in creating better outcomes and a better quality of life for your patients. And make sure to check out our other titles at Smith+Nephew Academy Online. Thanks for watching.